Be interesting. So the first, I would be presenting my cases of again Kumudini Sharma. हो गया इसको ऑन करो इस पे नहीं आ रहा last one. Okay. So I would be presenting some of the cases. Excuse me. भैया इसको थोड़ा फुल स्क्रीन पे कर दीजिए. ओके आ गया. ठीक है थैंक यू. इसको फुल स्क्रीन पे कर दो. फुल स्क्रीन कर देना. हाँ जी. So I would be presenting some of the cases which are not a very common presentation, and they would be mainly infranuclear. And first case is about a 22-year-old female. She presented with drooping of the left eyelid. Prior to this presentation, a week back, she had a fever with rigor, horocrinial headache, which was quite intractable, and she had a marked pain in the neck, which was increasing on neck bending. She was very photophobic, and she, along with all these features, she had upper respiratory tract infection. So all these symptoms, they are very much suggestive of viral meningitis. And we know viral meningitis is a very self-limiting, has a self-limiting course. So when she came to us, when we examined her acuity was normal, the ocular motif was very much suggestive of left third nerve palsy, she had a left third nerve palsy, while rest of the cranial nerve, neuro-ophthalmic examination, ocular examination, and neurological examination was normal. So we made a diagnosis of post-viral left third nerve palsy, and blood tests were normal. But still, as a viral meningitis, following that the nerve palsy is not very common, so we got the neuroimaging done to rule out any structural cause for that. So what we found, there was a thickening and enhancement of the third nerve, as pointed out by the arrow, in the subarachnoid part of its course. And this enhancement of third nerve in the subarachnoid course on MRI is seen in ischemic insult to the nerve, or inflammation or infection of the nerve by bacterial and fungal meningitis. The most common cranial nerves are involved in bacterial and fungal meningitis because a lot of exudations are there. Basal exudations are there in these type of meningitis, while in the viral, it's a very minimal CSF changes are there. And any neoplastic change of the neoplastic cause of the third nerve, like Sharma, is very much common, which can present as a cryptic third nerve palsy and ophthalmoplegic migraine. Now this term of ophthalmoplegic migraine is changed into the recurrent painful ophthalmoplegic neuropathy, because these patients do not have a very classical headache or a pain like a migraine. So these are the common causes of enhancement of the subarachnoid part of the third nerve on MRI. In our case, it was the inflammation of the third nerve, the post-viral demyelination of the third nerve that was responsible for disruption of the blood-brain barrier and enhancement of the nerve. We gave the steroid to the patient, and after the end of 1 month or 1.5 months, the patient third nerve resolved completely. So this is the inflammation of the subarachnoid part of the third nerve following the viral meningitis, which we all know it has a self-limiting course. So this case, we learned that a detailed history about the preceding symptoms is important to help to make a proper diagnosis of this condition. The common causes of third nerve palsy of the involvement of the subarachnoid part in this young patients are commonly the microvascular ischemia, not because of a vasculopathic cause, it's mainly the vasculitis. Second, the meningitis and the tumor of the nerve itself as schwannoma, or when there is a supratentorial tumor or a hemorrhage which causes tentorial herniation and trauma. These are the main common causes, but there is a long list of causes, but these are the main common causes of third nerve palsy in the young person which we come across in our practice. The second is again a young patient who presented with painless third nerve palsy of acute onset. And this patient, when we asked her whether she has any associated symptoms besides this third nerve palsy, besides the drooping of the lid, she admitted that she had a mild pain in both the limbs with mild swelling, and she had generalized body ache for last 1 month. The visual acuity examination was normal, and there was a right third nerve palsy which was complete, involving the pupil also. Rest of the neurological examination and neuroophthalmic ocular examination was normal. Since she was a young patient with acute onset of third nerve palsy, which we know below the age of 50 years is a vasculitis, which is a common cause of third nerve palsy, and after the age of 50 years a vasculopathic cause like diabetes, hypertension. Since we thought it might be a vasculitis, as she had a systemic symptoms also, we got the complete blood hemogram done. We found the inflammatory markers were raised, and we also asked for vasculitis, as it's a common cause of third nerve palsy in this age group. And we found out that all autoantibodies were raised with a decrease in the complement level. But the rest of the investigation like chemistry and the CT was normal. We thought it's because of the vasculitis. We referred the patient to immunology department, where the diagnosis of SLE was made, and she was given methylprednisolone. Even on the 4th day of the methylprednisolone, there was a marked improvement in her third nerve palsy. So this is a young patient in whom the third nerve palsy is a presenting sign of SLE. So third nerve involvement in SLE is due to damage of the endothelium or the vasa nervosa by the circulating antigen antibody complexes, or there would be a microthrombosis, as we know these patients are having a increased antiphospholipid antibody. So it's a kind of a ischemic third nerve palsy. So in a young patient with third nerve palsy who had a systemic symptoms, we should ask any associated symptoms are there or not. So the systemic symptom, a workup for autoimmune disease to rule out vasculitis as cause should be done. Now this third patient is about a 50-year-old patient who presented with sudden onset of vertical diplopia, but at the time of diplopia he had mild uneasiness in the head, and all these symptoms appeared when he was kicking his scooter. He was a known hypertensive, but the other systemic diseases were not there. The visual acuity was normal. The ocular motility was suggestive of left fourth nerve palsy. The rest of the ocular, neuroophthalmic, neurological examination was normal. And as we know, the fourth nerve palsy, the most common cause is trauma. The history of trauma was not there. Second most common cause is congenital one. But he didn't have any head posture, head tilt, and there was no increase in the vertical fusional amplitude. And we thought there might be some structural cause, because when the patient had an onset of diplopia, he had some mild uneasiness in the head, and he was kicking. That's why he was increasing. Doing a little bit of a raised pressure must be there because he was kicking. So we got the MRI done to rule out any structural cause, as the trauma and congenitus were ruled out. What we found out, there was a dilated vein in the left ambient cistern, as you can see in the MRI. And though these vessels must be there for a long time, and if you correlate the imaging with the neuroanatomy of this site, you can find out the fourth nerve is the one which comes out from the dorsal surface of the midbrain below the inferior colliculus. Then it winds around the cerebellar peduncles. And this course, it lies in the perimesencephalic, or what we call ambient cistern. And the location of our lesion is also at the same site, explaining the involvement of the fourth nerve. But these blood vessels would be there, they are soft, usually doesn't cause any compression. Why there is a palsy in this patient? The most probably, as he kicked, increases the intra-abdominal pressure, or these vessels are very weak vessels. And DSA was done, and it ruled out a dural AVM in the left ambient cistern. There were no indication of subarachnoid hemorrhage in this patient. So the fourth nerve palsy in this patient due to a perimesencephalic dural AVM might be because of a blood. These blood vessels must have bled in the substance of the fourth nerve, causing dysfunction of this fourth nerve activity. So while you see any patient with oculomotor disorder, take a proper history. That was the symptom of uneasiness at the time of diplopia led us to do neuroimaging. Otherwise, he was a hypertensive adult. We might have thought it is a vasculopathic cause. Vasculopathy is a more common cause of third, and next is the sixth, fourth come last in the list. So the additional symptom of uneasiness made us to do the neuroimaging, and we ruled out this pathology, and we referred the patient to neuroradiological intervention. This patient we had was operated by a neurosurgeon for the trigeminal neuralgia, trigeminal schwannoma. Following the neurosurgical operation, he developed left-sided sixth and mild seventh nerve palsy. So he had a double vision because of sixth nerve palsy, but he had marked burning and foreign body sensation in the left eye. These symptoms were there not before the surgery. So the visual acuity was normal. He had a left esotropia as the sixth nerve was involved, and corneal sensation were diminished, but they were better what he had before the surgery. So there was improvement in the sensation of the trigeminal nerve distribution. But the cornea was lustreless, and there was not much seventh nerve palsy. As you can see, the patient can shut his eyes properly. But the Sharma test showed a very poor reading on the left side. Anyone can suggest me what could be the cause of this dryness in this eye? Okay, the cause of dryness in this patient was, which was causing the burning and foreign body sensation to this patient, though his seventh was not that much involved, he would have leg of thalamus, and the fifth sensation have come back, and these symptoms were not there before the surgery. So the things have developed after the surgery. So it was a seventh nerve involvement. As you can see from the diagram, the seventh nerve in the lower one, the seventh nerve and the fifth is just above it, and the sixth is medial most now. So our lesion is over here. The CP angle tumor is over there, and if you correlate with the neuroanatomy, where the seventh nerve lies over there, and during the maneuver, neurosurgical maneuver, it is likely that 6 and 7s were damaged. And when 6th nerve comes out of the pons, it has two parts: the motor nerve, which supplies the facial muscles, and it has a nervus intermedius, which contains the secremotor fiber to the lacrimal and also to the submandibular sublingual glands. So because any lesion, any compression of the seventh nerve at the CP angle, or when it runs into the middle ear, in the petrous part of the temporal bone, where it contains the secretomotor fiber for the lacrimal, is damaged, it results into the damage to the parasympathetic innervation of the lacrimal nerve, which comes to the seventh nerve from the superior salivary nucleus, then to the seventh nervus intermedius, then geniculate ganglion. At the geniculate ganglion, these fibers left the main nerve, and they run into the gator petrosal nerve, and this gator petrosal nerve runs in the floor of the middle cranial fossa, and then it comes out to the foramen lacerum, and the fibers, they synapse in the spinopalatine ganglion, and then to the zygomatic branch of the maxillary nerve, it goes supply the parasympathetic fibers to the lacrimal. So this test will help us in differentiating whether it's a Bell's palsy, which is because of the involvement of 7 when it comes out the it comes out from this foramen and stenohyoid foramen. It comes out from that foramen. So the fiber, secretomotor fiber, they leave behind leave before the nerve comes out from this foramen. Hence, it's not involved, and you won't get any dryness of the eye. On the contrary, because the seventh nerve involvement is there is a more lacrimation. So any involvement of seventh nerve in the CP angle or in the petrous part of the temporal lobe or in the middle ear can result into the dryness of the eye because of the involvement of this secretomotor fiber. When this nerve will regenerate, as you know, any compressive lesion, there's a demyelination, then the remyelination. When the nerve will regenerate, which may take sometimes these fibers, which are supposed to go to the submandibular sublingual gland to the choroida tympani, they get misdirected, and they go into the gator petrosal nerve and supply to the lacrimal, which results into crocodile tear. This is the last case, which is about a 60-year-old man who was non-diabetic, non-hypertensive. When he came to us, he had a deviation of his right eye. He was unable to deviate his right eye laterally. That means he had a difficulty in abducting his right eye for last 3 weeks. Along with that, he had a very severe pain, very intractable pain in the right eye and a double vision. So when we examined, the visual acuity was subnormal in that eye, while in the left eye it was perfectly normal. He had a marked abduction restriction. He was not able to move his right eye beyond the midline. But if you can see, with so much of abduction restriction, there's very little bit of esotropia, while mostly in about 25% diopter, while the left eye was perfectly, and there was no proptosis in that eye. So my resident make a diagnosis of sixth nerve palsy. So when I examined, what I found, if there is so much of sixth nerve palsy that the eye was unable to move beyond the midline, there should be the adduction of this eye. Or there was a marked esotropia which was not there. And when I examined the adduction movement and the version movement, the restriction was equal. So both of these features are very much suggestive restrictive element as a limitation of abduction. Because if it had been a sixth nerve palsy, there would be a marked esotropia because the patient was not able to move eye beyond the midline. And secondly, the adduction should be better than version. So both the things were not there, so I thought it must be a restrictive type of limitation of the movement. There was a afferent pupillary defect in the right eye, but the rest of the examination was normal. As I thought it must be restrictive element because of the less esotropia and the equal limitation of abduction, induction and version. So I did the retropulsion of the globe. What I found, there was resistance over there. And the proptosis was not there in this patient because they have a lot of atrophy of the retrobulbar fat. We got the ultrasound done over there. What we found, there was a marked enlargement of lateral rectus muscle. It was heterogeneous echogenicity of the muscle was there. Considering the age of the patient, more than 60 years, with marked pain, with limitation of movement, enlargement of lateral rectus muscle, I thought it might be a metastasis in the lateral rectus muscle. So these are the causes of massive enlargement of extraocular muscles. The common is the thyroid ophthalmopathy. Then come metastasis, pseudotumor, myositis, or IgG4 related orbitopathy, or lymphoma, or amyloidosis, or following a trauma when there is a hematoma in the muscle. So in our case, looking at considering the age of the patient, resistance to retropulsion, enlargement of lateral rectus muscle, we thought it must be metastasis. When we got the MRI done, we found out there was a fusiform mass which was quite big in the size in the lateral rectus muscle, causing displacement of the optic nerve, which was responsive for subnormal vision, causing the compressive optic neuropathy with the subnormal vision in that eye. And the neuroradiologist also made the diagnosis of metastasis in the muscle, and the MRI shows the multiple mats in the cranial, in the brain also. So keeping that, we looked for the primary in this patient. The ultrasound abdomen was normal, but the CT chest showed was suggestive of bronchogenic carcinoma. So this is a case of bronchogenic carcinoma presenting as a metastasis in the lateral rectus muscle, presenting clinically as a marked restriction of abduction and a restrictive limitation of the movement. Thank you.
Thank you, ma'am, for that wonderful presentation. These were the cases which were out of box. You have to